Kia ora. Now, I know you've had to suffer through some of this information in the previous year's studies, so this presentation is just a quick recap on the basics of rhythm acquisition. We'll go on in class to talk more about specific rhythms. We'll briefly run through some of the basic concepts associated with cardiac ECG, acquisition, and the rhythms. So whether we're using a cardiac monitor or a 12-lead ECG machine, they're using conductive electrodes placed on the limbs or the chest wall to pick up electrical signals from the body. The electrical signals we're talking about are the ones generated by the electrical depolarization that causes the cardiac muscle to contract. Now, although these depolarizations don't involve large amounts of electricity, there's enough that they can be readily picked up by these electrodes. Now, the electrodes are quite efficient. They will pick up these depolarization sequences. Because the cardiac depolarization sequence is predictable and is repeated within the cardiac cycle time and time and time again, the cardiac monitoring equipment will also show a predictable and repetitive waveform if everything is going well. The electrical sequence can be seen from different angles, and although the various angles may appear to have different shapes, they are all describing the same event. It's merely being viewed from different angles. You might liken this to photographing your car from different angles. The front may appear different from the back, but if it's a good day, it's still going to be the same car. Careful placement of the electrodes ensures that the various angles of view are consistent from patient to patient. So from the clinician's perspective, this is going to allow for reliable interpretation of the waveform. In the emergency ambulance services, the majority of continuous cardiac monitoring is done using an ECG machine. The standard ECG reads 12 leads, and these leads are broken down into two groups. There are 6 that have a transverse view of the heart, that is a horizontal view, and they're known as the chest leads. The other 6 are the limb leads, and these provide a sagittal or a vertical view of the electrical events of the heart. So, continuous cardiac monitoring is normally achieved using the limb leads, and most commonly lead 2. However, any lead will suffice, and in certain situations, some leads offer a distinct advantage over others. The vertical axis on the ECG paper reads voltage, and so the larger the size of the waveform, the greater the voltage that has been captured. The horizontal axis measures time. The printer runs at a standard speed of 25 millimeters per second, and the divisions on the horizontal axis of the paper are a very accurate indication of how much time any waveform has taken to complete. So the inference we can take from this is that the wider a waveform is, the longer it's taken to occur over. So the last of these basic concepts that we're going to review is that a signal that moves towards a positive electrode produces a positive deflection on the ECG paper, and one that moves away from that electrode will produce a negative one. In terms of rhythm recognition, voltage and polarity, that is whether the signal is negative or positive, plays a relatively minor role. On the other hand, the duration of the time taken for an event to occur will play quite a significant role. So let's go on to recap the divisions on the ECG paper. So we know it's divided into larger and smaller squares. And on the horizontal axis, each big square is going to represent 0.2 of a second. So 5 of these big squares will be 1 second. There are 5 smaller squares within the large one. So it stands to reason that they are going to be 1/5 of 0.2 of a second. In other words, each little square will be 0.4 seconds long. While any limb lead can be used for monitoring purposes, the majority of cardiac monitors are set up to use the limb leads, and in particular lead 2, to provide monitoring. The theory is that it provides a thorough view through the long axis of the heart, and so the lead basically runs parallel with the main vector of the depolarization wave. Now this slide is going to show you the configuration for the 3 unipolar limb leads that we would normally use. Lead 1 looks across the base of the heart. The positive electrode is placed on the left arm, so any signal travelling towards that electrode is going to show as a positive deflection. inflection. Lead 3 has a view down the left side of the heart, and in this case the positive electrode is placed on the left leg. And finally, let's look at the standard monitoring lead we use, which is lead 2. In this case, as described before, its axis is from the right shoulder down towards the left leg, and so the orientation is pretty much from the base through to the apex of the heart, and hence considered useful because it looks at the longest axis. The positive lead in this case is placed on the left leg. There are some other limb leads. I'm not going to bore you with all the details, but they're known as the augmented limb leads, and hence the small a in front of the lead name. So we have an augmented left, augmented right, and an augmented foot lead. Assuming that the electrodes are put in the right place, there is a predictable angle of view that each of these leads will produce. Now, why this is not essential for cardiac monitoring, it plays a huge role when we do 12-lead analysis. So, just reiterating my point that lead placement is quite important. So there are 3 options for placement of the limb leads. And the traditional or the standard placement is the one that was developed for 12-lead ECGs. It remains the standard positioning for most ECG machines, including the LifePak 15. In the pre-hospital setting, however, this has the disadvantage that it's susceptible to artifact from skeletal muscle movement, and should the patient move their limbs or be shivering from the cold or whatever, or have significant muscle tension, this is going to be a problem. For this reason, many paramedics favour a position known as the Lund position. So the electrode placement for this is the one where we see people using the shoulders and the upper leg or the hip to do placement, and it was developed originally for continuous cardiac monitoring, but some ECG machines are now calibrated, and the core pulse may be one example of this. Final electrode placement is known as the Meissen-Likar system. Now, it was developed for stress testing, so this is when people are on a treadmill or whatever, and it's not recommended for ECG acquisition nor for continuous cardiac monitoring. However, there are times to reduce artifact that we have no option but to go to this, but it shouldn't be our standard limb lead positioning. Whichever electrode positioning system you use, make sure that the 4 electrodes are placed equidistant to the heart. And what we mean by this is if the right arm electrode is on the wrist, then the left arm electrode has to be on the wrist as well. If you're using the shoulders, both shoulders. Likewise, the equidistant rule applies between the upper limb leads and the lower limb leads. So if you're using the shoulders for the upper limb leads, it has to be the upper leg for the lower limb leads. And if you're using the wrist for the upper limb leads, it needs to be the ankles for the lower limb leads. Getting good results relies on good adhesion of the electrode. The way that paramedics can ensure this happens firstly is to store the electrodes so that they're not bent or creased, or that the cover on them is not damaged in any way, allowing the gel or the adhesion unit to dry out. Patient needs to have clean, dry skin so there's good adhesion, and there are times that we're going to have to use scissors or even a razor to remove excess hair to be able to get adhesion. And the last thing we need to do is limit movement. So this is all about reducing muscle tension and stress by having the person warm and comfortable, and sometimes we can get them to sit on their hands to help out with extraneous movement. Okay, that's the end of the Whirlwind Tour. I'll see you in class and we will discuss this a little further then. Ka kite.